Hello everyone, and welcome to Henry Schein's series on COVID-19 on YouTube. I'm Dr. Gary Severance with Henry Schein, and it's my pleasure to welcome back Dr. David Reznik, who will be updating us on all things related to the pandemic, including signs of recovery from the latest variant, and he'll also share a Swiss cheese analogy. Dr. Reznik, welcome.
Good day, everyone. As always, it's a pleasure to be here. And in this month, it's actually a special pleasure because there is some good news. I felt for the last couple of updates we had, Omicron was just taking over everything. Our hospitals were overflowing. There were concerns throughout the country. And now things are actually going in a more positive direction. So we're going to talk about some of those things and extra steps we can take to make sure that this does continue. So let's get started right away and look at our community transmission in the U.S. by county. Now, although it still looks high everywhere, we are seeing some places in the middle of our country that are blue. And last month, we didn't have any blue, nor did we have much yellow. We had all red and four little areas of orange. So you can actually tell now that there are areas of low transmission, and literally, we're beginning to come down from this awful spike the country has been through. One of the things that we really need to know is that boosters do work. COVID-19 cases and hospitalizations in January were the highest since the beginning of the pandemic, and we know that because Omicron is so highly contagious. We also know that there's a B2, there's a subvariant of Omicron that's out there that's even more contagious. But again, good news, it is not taking hold in the United States. And the information we have so far is that that variant, again, only causes a mild or moderate disease if you're vaccinated. It keeps you out of the hospital. As of February 10th, Omicron is still the predominant variant across the country. COVID data shows as of the 10th, 213 million people, or about 64.3% of our total population, have received a primary series of COVID-19 vaccine. So that is either your one shot of the J&J vaccine or your two shots of an mRNA vaccine. This doesn't mean that you've been boosted. And we know that boosting actually does help protect us from Omicron. So if you have patients or you have staff or family or people in your church or community, we really still need to be on that boosting message at the present time. Will this be the case forever? Our goal is no. We really want to get to the point where it's one shot once a year that's going to cover all the variants. And the good news is that researchers are actually working on that now. A little bit of a problem, and that's why here we come again as part of the primary healthcare team, is that only about half of the people who are eligible to get a booster have done so. And I'm going to talk about the side effects of the booster compared to the second shot, and I think that's actually some good news too. Everyone ages 12 years and older should get a booster shot if they've completed their primary series. So as we mentioned last month, that means that you're up to date. That's the new language that's coming out of the federal government. So being vaccinated means you've had your two shots of mRNA or your one shot of J&J. And I will say that news came out this week that J&J is going to stop producing their vaccine. There are some new vaccines that are soon to be approved by the FDA, one by Novavax. It is actually more of a traditional protein-based vaccine that has an adjunctive to it that makes it more effective. So you'll be hearing about that probably next month, but the J&J one-shot vaccine is literally getting ready to go away. We do know that Omicron is extraordinarily contagious. I think we've seen that through hospital cases, through emergency room visits, urgent care visits, etc. But the severity of the disease is lower. But the reason our hospitals have been so overwhelmed until now has been that there's so many people getting infected that those who are not, there's so many more people who are getting infected that even though it's a smaller percentage who have severe disease, it's still enough to overwhelm our hospital systems. As of February 9th, the current 7-day average, again, fabulous news, decreased 43% compared to the previous 7 days. So we heard this when it first in South Africa and then in other countries that have dealt with the Omicron wave. You get this remarkable buildup and then a very rapid decline in the number of cases. And so this is national data that I'm showing you. That we're seeing this big drop in the severity or the number of cases that we're seeing. So again, I love to say that we have good news. A total of 77 million COVID-19 cases have been reported in the United States as of February 9th. These are cases that have been reported. I am sure there are a lot of mild or moderate or completely asymptomatic cases that have not been reported. So that number is probably even larger. Again, back to good news, and I'm just so happy that I'm able to give good news for a change. Our new daily cases in a week fell 42%. That is extraordinary. COVID-related hospitalizations, 19%. Again, that is a remarkable drop in the number of cases. We're not seeing the deaths drop to that percentage, but they are going down. Remember, deaths from COVID lag. So you get your cases first, you get your hospitalizations, and then later on you'll see deaths fell. At our hospital, we really are tracking what is COVID-related deaths and then what are people who come in, say, in our trauma area that happen to be COVID. So we're only reporting COVID deaths if they're due to COVID in our hospital system. And our hospital system is doing, again, we're just mirroring what we saw nationally. And our hospital at one point had close to 300 people in the hospital. We were over 100%, 106%, so we're 6% over our capacity, meaning we had people boarding in the our incredible emergency department. But you can see we peaked at around 300, it was 290, and now literally we're hoping when today's number comes out, we're under 100 for the first time this year. So it looks like things are going in the right direction, both on the local level and on the national level where you are. And that is reflected in the first slide that I showed, because it's really important that you know your community transmission, because you could be in a high transmission area where you still need to take more precautions than if you're in a low transmission or minimal transmission area. And these are precautions when you're outside, not in the dental clinic. So we always want to know about innate protection that you might have from prior infection. And what we found that it offers less protection against Omicron. Immunity from COVID-19 infection actually provides less protection against reinfection from Omicron than other variants. And this is a study that was published in the New England Journal of Medicine. Prior infection still helps people avoid severe disease from the Omicron variant at a high level. The researchers found that previous infection was 56% effective at preventing reinfection with Omicron, compared with at least 86% against other variants, including 92% against the Delta variant. I know that we've been talking about Omicron so long, but remember, Delta caused more severe illness, and that was replaced by Omicron. And so we do know that if you've had a previous infection, you have some innate ability to fight off a Delta variant, but we're not seeing that right now. Across the United States, the variant that we're dealing with is Omicron. It's almost 99% of the cases. Previous infection was 88% effective at preventing severe, critical, or fatal COVID-19 from Omicron. So that is good news. They're consistent with other reports about reinfection and breakthrough cases with Omicron, according to a USA Today study. Scientists have confirmed that Omicron is more transmissible and able to evade immunity, though it causes less severe disease in most cases. It doesn't mean that you're not going to be knocked down if you get it. So my advice is do whatever you can to be one of those people, to not get infected. Take all of your safety measures. What we do in the dental office, we are in a safe environment in the dental office. We have been doing great infection control practices. We have done things like wearing N95s at the beginning of the pandemic when they were available. We have our extraoral evacuation systems, our high volume suction, our rubber dam placement, our HEPA filtration units, working on getting the airflow to be better. So there's so many things that we are doing in the dental profession that are helpful, but these things need to follow us to a degree when we're out. So if you're going to dinner, it depends on which state you are. New York has dropped the mandatory mask rule. I did go out for Valentine's dinner in Atlanta when I know what our cases were. I wore a mask to get into the check-in, and then when I proceeded to my table, I took the mask off and felt very comfortable. So it just really depends on where your infection level is in your community and doing things that will help keep us all safe. I think that's the goal. Remember, again, we're part of the primary healthcare team. So look at the vaccine effectiveness against hospitalization. If you look at where we were with 2 doses, and if you look at the red line, which is Omicron, you can see that the effectiveness of 2 doses really does drop down to about 57%, where in the same case with hospitalizations with Delta, that number was much higher at 81%. But after you get that 3rd dose, at least for a period of time, you go back up to around 90% effectiveness about being hospitalized. And as someone who works at a hospital that has been strained by this pandemic for some time, I strongly recommend getting that 3rd dose. The issue that we're going to find is how long does the 3rd dose last? Does it last 6 months? Does it last 4 months, which is actually what we're seeing at this point? And again, we really need to look at the research as it comes out, because getting boosters every 6 months or boosters every 5 months isn't going to be workable. We already know that we're having a lot of people that aren't getting this initial booster, no less looking for maybe a 4th booster. So we really have to help our patients stay up to date with their effective vaccines. So I was just sort of alluding to this. The booster effectiveness does wane after about 4 months. And this is looking at Pfizer, BioNTech, and Moderna vaccine lose substantial effectiveness after about 4 months, but still provided significant protection for keeping people out of the hospital during the surge. So yes, they're not as effective. It does drop down in 4 months, but it does keep people out of the hospital. This was a study published by the CDC. The vaccine was 91% effective in preventing a vaccinated person from being hospitalized during the first 2 months after the booster, but after 4 months, the protection fell to 78%. Protection faded more in preventing trips to urgent care and emergency departments, falling from 87% in the first 2 months to 66% after 4 months. So as you can see, the booster works, but it has a limited amount of time that it does work. And so what our hope is, since we're seeing the number of cases really reduced in the United States, that we're going to have a period of time between now and hopefully July, where the cases are going to continue to go down and we're going to be able to get back to a certain level of normal. That is my hope. We'll just have to see what time will tell. So look at the safety monitoring about vaccine boosters. I think this might come as a bit of a surprise to people. In pre-authorization trials, adverse reactions were reported less frequently following COVID-19 MR vaccinated booster than after receipt of the 2nd primary dose. So I know many people, when they got their 2nd dose, they had muscle aches, they were tired, they just didn't feel good, and that's why we were eventually at the beginning we were giving some time off about this. But now we know that the booster actually doesn't cause as bad a set of symptoms as getting the 2nd dose. Looking at surveillance data that found local and systemic reactions were less frequently after COVID mRNA vaccine booster dose than after the 2nd primary dose. And something that has become an issue is myocarditis. It was rarely reported following an mRNA vaccine booster dose. Myocarditis is much more prevalent in people who aren't vaccinated, who do get COVID. And this long COVID that we're dealing with is actually a real issue, and it impacts a lot of people. But myocarditis does not really come from getting the booster dose. And I think that's important because that is keeping people away from getting vaccinated. All people aged 12 and above should receive the COVID-19 booster. As I talked to earlier, vaccine providers should educate patients that local and systemic reactions are expected, but they'll be less, and they're less common than they had when they got their second dose. So we want to encourage people, saying if you had a bad experience with your second dose, really the data is showing that getting a booster is not going to make you feel worse. If we look at weekly hospitalizations for U.S. adults age 50 to 64, and we're really talking about, what I'm talking about here is going to be specific to vulnerable populations. But let's just look at weekly hospitalizations for U.S. adults age 50 to 64. The vast majority of the cases that we have had in Atlanta, the vast majority of cases that we've had around the country are in those who are unvaccinated. If you've been vaccinated but didn't get a booster, look how much protection you still had. And then if you did get boosted, look how much protection there. Your chances of ending up in a hospital are minimal, if any. So the whole goal, you can see this large differentiation between where unvaccinated people are and where vaccinated with and without boosters are. And I thought this was a really important slide to show you on how important it is to get vaccinated. The CDC updated its guidance on protecting vulnerable people from COVID this month, and for people that have weakened immune systems. So it's about 2.7 million people, and we're really going to talk about them for a while because they could be people in our families, they could be our patients, they could be members of our staff. And what they're doing is they're recommending a booster dose of the coronavirus vaccine 3 months after completing the initial series. We were waiting 6 months for a period of time. But now for people who are vulnerable, for people who may have a weakened immune system, maybe untreated HIV or oncology care, that we need to get that booster in place sooner. The guidance also said that for immunocompromised people who get the one-shot J&J vaccine, they should definitely get an additional dose. That means 2 doses, at least 28 days apart, followed by a booster dose of one of the mRNA vaccines. So we're boosting the mRNA vaccines presently with other mRNA vaccines. So you might have had Pfizer BioNTech for your first 2, and then you get boosted by Pfizer. Or you might have had Moderna for 1 and 2, then you get boosted by Moderna, if it's available. However, with J&J, you get the 2 doses to be covered, and then your booster needs to be, at this point, an mRNA vaccine. But as I've mentioned, there is a protein-based vaccine that hopefully will soon be approved by the FDA by a company called Novavax that hopefully will encourage people who are afraid of getting this relatively new technology. I remember when we first started talking about this, maybe a year and a half ago, that the mRNA technology at that point had been around 10, 15 years. It's not brand new technology, but we had a brand new pandemic. We had a really good way of getting people to be safe and out of the hospital, and it's working with our present vaccines that we have. But for those who are afraid of the mRNA vaccines, there will be another option, hopefully approved in the United States soon. The option that I'm talking about has been approved by the European Union and several other countries throughout the globe. The updated guidance also says it's no longer necessary for people to delay coronavirus vaccine after getting treatments with monoclonal antibodies. Previously, if you got treated with monoclonal antibodies, you had to wait 3 months until you get vaccinated. Treatment is authorized for early stage COVID-19 or with convalescent plasma. Again, you don't have to wait. You can get vaccinated right away. Convalescent plasma is taken from blood donated by people who have recovered from COVID-19. The CDC also recommends people with weak immune systems receive 3 primary shots of the mRNA plus a booster. So that's 4 shots. given the less than optimal immune response that somebody maybe with undiagnosed or untreated HIV would have. That's my area of expertise. They have basically a less than optimal response. We can increase that with the 3 doses, and then a booster at 3 months may provide better protection. So we're really worried about Omicron and our most vulnerable people, and that's what the CDC is trying to address. As I said earlier, the CDC says there are about 2.7% of our adults, or about 7 million people, are immunocompromised. And some of these folks are people who have medical conditions that weaken their immune response, as well as people taking immune suppressing medications because of organ transplants. They're having oncology care or autoimmune diseases. Also on the list, and I include this because this is the clinic that I work in, people with advanced or untreated HIV infection, and those who have chronic medical conditions that can weaken the immune response, such as chronic kidney disease. So we don't authorize these. Our primary care folks do, our nursing staffs do. So we really need just to be aware where our patients should be. So if you have a person on dialysis, it might be good to check and see if they need to get these extra doses. And here for our untreated patients, and we don't have very many that are untreated, but we have some, then we are actually upping their vaccine doses, following the CDC recommendation. Here's just a chart. Now, these are for people with moderate or severe immunosuppression. These are not for people like you and me, hopefully, that are not immunosuppressed, that are healthy. So for Pfizer, and you're greater than 12 years or older, number of primary vaccines for these people with moderate, severe immunocompromised positions are 3, followed by 1 booster. The intervals you can see. This is a great chart just to have around if you know that you're treating people who have moderate or severe immunosuppression. Again, the Janssen or J&J, it's 1 Janssen followed by 1 mRNA, and then a booster that's 4 weeks later. So you get the idea that we're really giving a bit of more protection for those who are more vulnerable. Really what we want to have, and our goal, is that we could have a single vaccine that can protect us against all variants. And that would be a 1 shot once a year, just like we get our flu vaccine 1 shot once a year, and even ward off entirely new coronaviruses down the road. So we are working on that. Not me personally, but research is underway, and we hope to get some results soon. So health experts broadly agree that this constant getting boosted is just not going to work. And we can see just from the original booster, the hesitation. Only 62% of people in America who are eligible for vaccine have been fully vaccinated. We're not even talking about being up to date. So this idea of constantly getting boosted shots isn't sitting well with people for multiple reasons. And we really would hope that during the research that's taking place, and we know that everybody is working on coronavirus right now, that we can get a pan-coronavirus vaccine. That is a dream, and that would be something that would be wonderful. So again, a guide to protecting those that are more vulnerable from COVID, high quality masks. And I've showed you the Swiss cheese model before, and I am going to show it again, because if you do several steps, you can literally help people stay out of the hospital. So for high quality masks, which could be KN95s or N95s, that is one of the things that is helpful in preventing transmission. The multifaceted approach, which each strategy, including vaccines, has holes in it. You're not going to get 100% coverage, but you add the mask to it. You add getting boosting to it. Looking at preventive drugs, there's an FDA new drug called Evusheld made by AstraZeneca that is now available. There are treatment drugs that are available. And so we need to look at all of our different tools, but this is a new preventive drug. It's designed to be an additional layer of protection on top of vaccines to prevent COVID in immunocompromised patients. Rapid testing. The government was handing out 4 rapid tests. I don't know if you've received yours. I actually have not received mine yet, but they're sending it. All you had to do is fill out a simple form, and they were going to send these rapid tests to your home. There are dental offices that I'm very proud to say are offering rapid tests, integrating medical and dental together, which is our goal. So one recent piece of good news is the increased availability of these rapid tests. They were very hard to find, but they're available in drugstores. They're available in several areas. And we have post-infection treatments that are available, like Paxlovid. The FDA on the first part of February authorized a new antibody treatment from Eli Lilly, adding another option because we know that some of our monoclonal antibodies that we use to treat Delta and other versions are not effective against Omicron. But this new treatment works against Omicron and is authorized for treatment of mild to moderate COVID-19 in people that are 12 years and older or who are at high risk for disease. The agency limited its recommendation by saying it would be used in patients for whom alternate COVID-19 treatment options approved or authorized by the FDA are not accessible or clinically appropriate. So we do have new things that are being approved all the time by the FDA. And it's also good news that it looks like we finally have someone who is in charge of the FDA, and that position has been open for too long. Infection control. So, due to concerns about the increased transmissibility of the SARS-CoV-2 Omicron variant, the guidance was being updated by the CDC to protect healthcare personnel, patients, and visitors to address concerns about potential impacts on the health system. As you've heard, or you turn on your television, our frontline health workers are just overwhelmed. Our nursing shortage is at a crucial level in the United States. We have a significant nursing shortage in Atlanta. And we have people who are leaving the profession because they just got burned out. So empiric use of transmission-based precautions is recommended for patients who've had a close contact with someone who's been infected if they're not up to date with all of their vaccines. But quarantine is not needed for asymptomatic patients who are up to date with all of their recommended COVID-19 vaccine doses or who have recovered from SARS-CoV-2 infection in the prior 90 days. So some of these things are changing, and our goal here is to try to keep people up to date. Impact of hand hygiene strategies for skin barrier function. Healthcare workers were randomized into hand washing with water and soap, or applying an alcohol-based hand sanitizer, or using disinfectant wipes. So I did take a trip. I went up to Yankee Dental, and when I got on the plane, as you're walking into the plane, the flight attendant was actually handing out disinfecting wipes. I actually carry my own disinfectant wherever I go, but I thought that was really cool. Not the best thing, but it's better than nothing. Transepidermal water loss was greater with the use of disinfectant wipes, and interestingly was reduced with the use of the alcohol-based hand sanitizers. And there's been studies that have been done for a long time that are really showing that if for non-soiled hands, the use of alcohol-based hand sanitizers was the best. It reduced the colony-forming units as better than just soap and water or using the wipes. Alcohol-based hand sanitizer shows the least impairment to the skin barrier and the most reduction in colony-forming units. And I think it's important that when you do pick out your hand sanitizer, find one that is not going to be sticky. There are some newer products out on the market that are really wonderful, that make your hands feel like almost like they're silicone, that they're protected. You don't feel the water loss. Your hands won't crack. And so one of the issues in dentistry is we really want to make sure that our hand integrity is good. That's why using these alcohol-based hand sanitizers, at least a good brand, is really something that's important to do. Drill selection may affect COVID-19 transmission. And so my nephew went to the University of Alabama at Birmingham School of Dental Medicine, very proud to say, and he did a GPR at the Dental College of Georgia. And he uses a lot of electric drills. I'm an older dentist. I just built a new clinic, and I really didn't install any electric drills. And maybe that was a mistake, but something that we can deal with on a later day. But Health Day reports new research suggesting that dentists can significantly improve patient safety by switching the type of drill they use. The studies used a harmless virus similar in size and structure to SARS-CoV-2 to compare the aerosol spray patterns produced by conventional air-driven drills and the newer electric drills. They found the electric drills produced 99.98% less aerosol spread of the virus in the air compared to our normal drills. And that's when a dental suction tool was used with the electric drill. It's not going to happen by itself. We still need to use all of those things that we've been talking about. Isolating the tooth with a rubber dam, extraoral evacuation, barriers or isolite for our dental hygiene, having HEPA filtration, all those different things. But what they found was there was no detectable virus on surface or in air samples taken 6 to 10 minutes afterwards. Researchers also found that changing from air to electric drills can significantly reduce the time needed between appointments to make dental spaces safe, potentially enable dentists or dental hygienists, but dentists to use many more patients, to see many more patients during the pandemic. And this was a study published in the Journal of Dental Research. Actually, I was asked that question, do we still need to keep that 15 minutes in between patients? In my office, we're not doing that because we leave our extraoral evacuation systems on high in between patients. We have HEPA filtration going on. So by the time that we have taken the equipment, we put it in our red, solid, biohazard labeled containers and transported it to our dirty room. And then by the time you do that and you wipe your surfaces down and let them stay according to manufacturer's instruction use, it doesn't, by the time all that happens, it's time to go ahead and see the patient. So we're not waiting 15 minutes. We're actually increasing our productivity, and we are actually at pre-COVID productivity now in this clinic, and that's very encouraging to me. So again, the Swiss cheese model that I always like to talk about, it's recognizing that no one single thing that we can do will prevent the spread of this disease. And as Omicron goes away, I hope it becomes an endemic infection that we don't have to worry about new variants, but that's a little bit wishful thinking. We don't know what the future holds. And if you look what happened historically at the Spanish flu, the 1918 flu, that when we got to a point like this, people got tired, they stopped doing protective things, and when we had another huge wave. So the goal here is for us to maintain what we've done. We've done an extraordinary job in dental offices. I think we probably have been one of the most effective places because of the infection control protocols we had put in place based on bloodborne pathogens. We are just adding N95 masks and air quality improvements to it. So if you physically, one of the issues we have, and we have it at the hospital, and I'm sure you have it at some of your offices, if people are sick, if they are running a fever, they really need to stay home. And I know people want to come into work for their paycheck, but if you're sick, they should stay home. Masks offer another level of protection, and these are personal responsibilities, things that we can do to make sure that we are not spreading it. Hand hygiene. So when you're using those alcohol-based hand sanitizers, remember that we still have to use it for 2 minutes, and we have to cover all aspects of the hands and the nails. So it's actually going through the whole process. So if you're not getting a 2-minute amount, you're not putting enough on. So it should be 2 minutes of hand washing or 2 minutes of hand sanitizer. Cough etiquette seems to be going away. I've actually noticed people at the hospital who are coughing into their hands. When you cough, you should cough into the inside part of your elbow. But hand hygiene needs to occur on a regular basis. Avoid touching your face. We touch our face thousands of times a day. But when we're masked and shielded, we can't touch our face. But these are just things that we're doing out in the real world. Then, having good testing available, rapid testing, ventilation, and air filtration. These are shared responsibilities that we're doing. Getting government messaging, which has been a bit on the confusing side, and financial support, which we did have for a while, and then vaccines. So if you follow the angle that arrow, it really can't make it through all these things and infect somebody else. And that is our goal. Each layer has imperfection. There's not 100% vaccine. We can get some false positives or false negatives on some of the tests. Physical distancing, it's really hard to do in some dental offices. But each intervention, each layer helps address these holes that we see. And if you have multiple layers, you're going to improve success. So what about periodontal disease and COVID-19? Is there a correlation? Is it causal? Is it causal? How do these things work? Chronic systemic inflammation, we know, is a major risk factor for severe forms of COVID-19. In January of 22, the European Journal of Dentistry published a peer-reviewed paper suggesting that the existence of periodontal disease can be a contributing factor in severe COVID-19 infection. Why? Because periodontal disease is a sort of inflammation, and inflammation is a driving cause in many chronic diseases and in many severe diseases. On January 13th of 2022, the authors of a Frontiers in Pharmacology study said that COVID-19 has been associated with periodontitis and that both conditions share an inflammatory and infectious nature. So again, by doing what we do, treating periodontal disease, we can help reduce inflammation and hopefully help, if someone does get COVID, prevent severe disease. Significant changes take place in both the gut microbiome and airway, and even the oral microbiome when people are infected with SARS-CoV-2. Pathogenic bacteria proliferate and beneficial bacteria diminish, so making us more likely to have inflammation. Overgrowth of harmful bacteria in the gut may encourage the development of COVID-19 through interactions with angiotensin converting enzyme, or the ACE2 enzymes we talked about before, mitochondria, and the lung-gut axis. While dental healthcare professionals diagnose and manage active periodontal disease, other patient factors must be brought under control along with treating them, and that could be proper diet to help. So we also do nutritional counseling, something that we can charge for, something that's a benefit to our patients. We do oral hygiene. We take care of periodontal disease. So we're literally reducing a lot of inflammation, which can impact a lot of systemic diseases. That's why dental hygiene is such an important part of what we do. What about heart risks? People who have had COVID-19 are at an increased risk of heart disease 12 months after infection, a danger that is substantial and spans an array of heart and vascular disorders. One of my dearest friends and colleagues actually ended up getting COVID, ended up being in the hospital for atrial fibrillation. So we really have to watch out for these things. Another reason to avoid COVID-19 at all costs. The study is important because it underscores not just the acute cardiovascular risk associated with COVID, but the increased risk of chronic cardiovascular outcomes as well. Given the number of people in the United States who have been infected with COVID because of the Omicron variant, this could represent a significant chronic burden on the healthcare system. And we already know our healthcare system is stretched beyond belief. And we're also seeing, as I mentioned earlier, a lot of people in the healthcare profession leave. I don't think it's a time to leave. I think it's time to call to action for us, because we can address periodontal disease, and even COVID could be in carious lesions. So what we can do to protect our patients is significant. For the study, the investigators looked at the National VA database to analyze health data of almost 154,000 veterans with COVID-19 between March 1, 2020 and January of 21. They were compared with another group of 5.6 million veterans who never tested positive for COVID-19, and a third group of 5.8 million veterans using the system in 2017 prior to the pandemic. At the study published in Nature Medicine found the risk of major heart event, which included heart attack, stroke, and all causes of mortality, was 4% higher for people who have been infected with COVID-19. You might say that 4% is small, but actually it's a really, really big number if you think about the number, the millions I talked about at the beginning of this presentation who have had COVID-19 in the United States and globally. This is a global pandemic. COVID-19, not vaccinations, but women infected with COVID-19 have had a higher chance of complications during pregnancy than women who were not infected. And this was another study funded by the NIH. Researchers found that women with severe to moderate infection, not mild disease, but severe to moderate infection, were more likely to require a cesarean delivery, deliver preterm, die during childbirth, what a terrible thing that would be, or experience postpartum hemorrhaging or an infection other than COVID-19. They're also more likely to lose a pregnancy or have a baby die during the newborn period. So these are terrible things. We really don't want women who are pregnant or at risk for pregnant to get COVID. So women with mild to asymptomatic infection didn't experience these pregnancy risks. So these are only for women with severe to moderate infection. But if my wife or your wife wasn't vaccinated and had mild to moderate disease during pregnancy, it could be a terrible outcome and one that we really must avoid at all costs. The babies were delivered between March 1 and December 31, 2020, before the vaccines were widely available. So the findings really underscored the need for women of childbearing age and pregnant individuals to be vaccinated and take other precautions, remember our Swiss cheese model, against becoming infected with SARS-CoV-2. That's the best way to protect pregnant women and their babies. And this was by the director of NIH's Eunice Kennedy Shriver National Institute of Child Health and Human Development. The CDC recommends that COVID vaccine for people who are pregnant, breastfeeding, trying to get pregnant, or may become pregnant in the future. So I think that's a pretty strong statement. In a separate NIH-funded studies, researchers found that being vaccinated against COVID-19 did not reduce the chances of conception in about 2,000 couples in the study. However, the study found that COVID infection may be linked to short-term reduction in male fertility, according to another NIH news release. So the goal is just get vaccinated. That is the key. And that's a way to safely have children during this pandemic. So what about this COVID-19 vaccine or test requirement? For large workplaces, how does that impact our profession? As we know, the courts upheld the vaccine mandate for workers at federally funded healthcare facilities. The rule affects dentists working in Medicaid and Medicare facilities such as hospitals, like myself, ambulatory surgical centers, our oral surgery colleagues, dentists who would work in nursing homes, and federally qualified health centers. I know there's a great deal of people who watch this from the FQHC world, and those who have hospital privileges or work for the Indian Health Service. So those individuals, including myself, have to be vaccinated and need to be up to date. The rule does not affect private dental offices. So if you accept Medicaid, Medicare only covers the minimal kinds of oral health things at best. But if you're accepting Medicaid or Medicare and you're in a private office, these mandates do not count for you. Only for dentists working, dental healthcare professionals, it's not just dentists, working in Medicare or Medicaid facilities such as hospitals, ambulatory surgical centers, nursing homes, FQHCs, and those who have hospital privileges or were in the Indian Health Service. If you, like my nephew, just opened up Peach Dental in Atlanta, I'm so proud of him. And he does accept Medicaid. He does not have to be included in this mandate. And this is from the ADA publication that came out in January. I've been doing these webinars now for a couple of years. I will be speaking at Thrive Live 22 at the Bellagio in Las Vegas in April, and I would be so joyful to be able to meet some of you and share some of this information in person. It's going to be a remarkable event with great speakers. I signed up for courses. I'm in Vegas, and I'll be taking courses along with you the entire time, and then I'll be giving my presentation. And there's nothing more satisfying than getting questions from the audience at the time of the presentation. To meet some of you that have been following these presentations these last few years, it would be a remarkable privilege. So I do hope to see you at this remarkable conference that will be coming up very soon, April 7th through 9th. And it's my hope, if we're following some of the pathways, that we'll be on a way slope downward with COVID infections, and that we all can have a great time meeting each other and spending time learning together at Thrive Live 2022. So thank you. I know that Dr. Severance will be coming up in a section, but if you have questions about today's presentation, please go ahead and send them in. I do my best to try to answer those questions. If there are topics that you would like us to cover in our March presentation, please don't hesitate to offer those suggestions. As I always say, it's an honor to be able to present this information. I go through a lot of different things trying to find out what I think will be most helpful, and getting your input would really be helpful to me. So I'm going to turn it back to Dr. Severance. As always, thank you for the opportunity, and I hope to see you at Thrive Live 2022.
Thank you, Dr. Reznik, for the continual updates, and thank you for watching. Please email us any questions, concerns, or requests for future topics at webinars@henryschein.com. And please subscribe to our YouTube page by clicking the subscribe button below. And to be notified of any premieres, click the bell icon. Thank you once again for your attention. Please stay safe and stay informed, and we'll see you at Thrive Live 2022.